be hearing from Dr. Megan Rogers for our featured presentation. Dr. Rogers is an assistant professor in the Department of Psychology at Texas State University and a faculty fellow in the Office of Translational Health Research at the university as well. Dr. Rogers will walk us through her extensive research on suicide risk assessment and management. And now I will turn over the conversation to Dr. Rogers to get us started.
Great, thank you, Lauren. I'm going to go ahead and share my screen. Okay, just double checking that this is all displaying correctly. All right.
Yes, we can see.
Okay, fantastic. So thank you again for that introduction. So again, my name is Megan Rogers, Assistant Professor, Department of Psychology at Texas State University. My research predominantly focuses on transdiagnostic, or what I mean by that is like non-disorder specific risk factors for suicidal thoughts and behaviors, with an emphasis on acute suicidal crises. Ultimately, I hope through my research to improve our understanding, our assessment, as well as our prevention of suicide-related outcomes. Today, I'm just going to be giving a snippet of a workshop that I typically give on suicide risk assessment and management. So this is not necessarily just focusing on my research, though I have done a lot of research in all of these areas. But I just really want to give kind of a general overview of proximal as well as indirect indicators of suicide risk, as well as how these factors can be incorporated into suicide risk assessments and interventions. So just to give a little bit of an overview and a roadmap for what I'm going to be discussing today, I'm just going to give first a quick overview of traditional suicide risk assessments and highlight some of the limitations of relying simply on suicidal ideation. I'm then going to introduce several indirect and proximal indicators of suicide risk across domains, talk about their potential relevancy to suicide, as well as provide some examples for how these risk factors might be assessed kind of within a suicide risk assessment. I'd love to get a little bit deeper into the weeds and provide a little bit more research evidence on acute suicidal crises, as well as like suicide risk management, so things like safety planning, lethal means counseling, et cetera. But our time is unfortunately limited today. First, I just want to start out by getting a sense. I've been seeing some of the comments and introductions rolling on the chat. I would just love to kind of get a little bit more information about what familiarity level you all already have with suicide risk assessments. If you don't mind just kind of putting that in the chat, and I'll be kind of glancing at those as I speak today. But I first want to go ahead and highlight some of the prevalence rates associated with suicidal thoughts, attempts, and deaths. So each year, over 47,000 people in the United States die by suicide, making suicide approximately the 10th leading cause of death and a major public health concern. Worldwide, this figure blossoms to nearly 800,000 deaths globally each year. Our estimates also suggest that for every death by suicide, approximately 25 non-lethal suicide attempts occur. And these estimates also suggest that countless individuals, approximately 1 million, at least in the United States alone, are experiencing serious thoughts of suicide each year. So accordingly, there's been some pretty substantial research and work done to develop suicide risk assessments, predictions, as well as prevention protocols. These traditional and established guidelines for suicide risk assessment are typically going to emphasize identifying individuals with suicidal ideation or those with a history of suicide attempts in order to predict current risk and connect individuals with appropriate care. So typically, our prior or our current suicidal thoughts and behaviors are often cited as these robust predictors of future suicidal behavior, as can be seen by the large number of interviews and self-report measures that are assessing these constructs. I want to zoom in just briefly on one of these. So specifically, let's look at the Columbia Suicide Severity Rating Scale as an example here. The CSSRS screener is pretty widely used across multiple settings, such as primary care, emergency departments, outpatient clinics, among others, as an assessment of current suicide risk. It's primarily assessing suicidal ideations, plans, intentions to act, as well as lifetime and more recent suicidal behaviors, including preparations for suicide and various types of suicide attempts. From there, patients are typically classified as being at either no risk, mild risk, moderate risk, or severe risk. I want to note that although this measure has demonstrated relatively good psychometric properties, supporting its reliability and validity, there's also several issues that are related to its exclusive use in suicide risk assessment. Note that I don't intend to just call out the CSSRS by itself. It's just one of the more well-known examples out there, as it's one of the most widely used interviews. But these limitations tend to apply to all of these measures. So in particular, one limitation is that prevalence rates of suicidal ideation are much, much, much higher than rates of suicide attempts, as only a minority of individuals with suicidal ideation ever actually go on to engage in suicidal behavior. So suicidal ideation alone is a poor predictor of suicidal behavior. And likewise, a meta-analysis from about 9 years ago now synthesized the existing longitudinal literature at that time, and again found that suicidal ideation by itself is a relatively weak predictor of future attempts and deaths. Suicide attempt histories don't perform much better. They are relatively stronger predictors than current ideation, but they're current relatively weak predictors of future attempts and deaths as a whole. And when clinicians are tasked with determining risk over short timeframes, so timeframes ranging from days to weeks or sometimes even hours, these figures are especially problematic. Similarly, a recent editorial that came out a couple years ago further highlights this limitation. They noted that about half of the patients who died by suicide within a month and fewer than half who died within a year actually screened positive at the optimal CSSRS cutoff, leading those authors to conclude that this screener should not be used to guide provision of psychiatric services in emergency settings, given its poor classification accuracy and predictive utility. Another limitation here is that suicidal ideation fluctuates pretty substantially over the course of even hours, which can lead to recall biases. It can also escalate rapidly or fluctuate pretty rapidly, which may lead to suicide attempts without much warning. There's several emerging studies now that are suggesting that suicide ideation can be pretty transient. It can fluctuate pretty substantially in intensity over time, and it tends to be relatively unstable. So the graph that I'm displaying on this slide is just one exemplar from a paper published a few years ago that's illustrating this phenomenon. Participants in this study completed real-time assessments of their suicidality 4 times a day over a period of 28 days. And this figure here is showing those fluctuations in suicidal ideation over time, with a few random participants here that are highlighted and colored for emphasis. But what you can really see here is that trajectories of suicidal ideation differed pretty significantly across participants, but was also relatively unstable for most of those participants. These fluctuations can lead to recall bias. Another recent study illustrated that the majority of participants who reported suicidal ideation using this real-time monitoring approach actually denied any past week ideation on a retrospective measure at the end of that week. So what this means is that we might be missing people who are at risk by relying solely on the assessment of ideation during these weekly sessions. And then finally, many individuals choose not to disclose suicidal ideation or intent at all when it's present. So there's been several studies that have shown that up to 75% of patients and those general community members explicitly denied suicidality during their final communications with healthcare providers. Approximately half of individuals who report lifetime ideation deny ever telling anybody about those thoughts. There's a number of factors that may contribute to this non-disclosure, including fears associated with loss of autonomy, involuntary hospitalizations, embarrassment, stigma-related factors, shame, rejection. The list goes on. And we also know that rates of non-disclosure may be higher among higher risk groups. So this may include military service members and veterans, sexual and gender diverse individuals, older adults. And there's also some evidence to suggest that lower rates of self-disclosure may actually be associated with greater seriousness and lethality of the behavior. So it's crucial to identify other avenues of determining risk that don't necessarily rely solely on the disclosure or the identification of suicidal ideation when it's present. All in all, highlighting these limitations is not to say that suicidal ideation is not important. It very much is. It's clinically informative, it's useful for decision making, it's useful for subsequent interventions, including interventions in its own right. Suicidal ideation significantly impairs quality of life. However, it should not be solely relied upon in predicting the possibility of future suicide attempts and deaths. So next, I want to introduce some indirect and proximal indicators of suicide risk that can be used to augment some of these traditional risk assessments. All of the ones that I'm going to be presenting on today are empirically supported by a number of studies that are continuing to be ongoing today. I do want to highlight that there are some ways to detect implicit risk for suicide, including things like the death or suicide implicit association test. the suicide Stroop task, which is identifying attentional biases towards suicide-related cues, as well as machine learning techniques that can be used to predict suicide from large data sets, including things like electronic medical records. However, despite the potential promise of these techniques and some of the evidence, weak versus strong kind of among them, we still know that interview and self-report methods are currently the most accessible, rapid, cost-effective, as well as prevalent methods of screening and assessment. So for the rest of this session, I'm planning to focus on some of these research-backed risk factors that can be assessed directly via these self-report and interview methods. So I'm going to start by highlighting just some prominent theories of suicide that can be used to guide suicide risk assessment and intervention. These theories are going to emphasize the importance of interpersonal as well as cognitive affective factors, alongside a focus on one's capability to engage in lethal self-harm. I'm then going to discuss stressful life events, which are acute and proximal predictors of suicide attempts. And then lastly, I'm going to discuss some hyperarousal and acute affective states that have been shown to relate to more short-term risk. So, specifically, the first theory that I want to discuss is the interpersonal theory, which proposes that two dynamic and malleable cognitive affective states, so perceived burdensomeness or feeling as though one's a liability on others or on the world, as well as thwarted belongingness, which can be conceptualized as like loneliness or social disconnection, a lack of reciprocal care, are contributing to one's desire to die by suicide. However, this theory proposes that only individuals who possess sufficient capability to engage in suicidal actions are actually going to go on to be at high risk for death by suicide or for making a serious suicide attempt. So the interpersonal theory has accumulated pretty substantial empirical support over the years in a wide variety of populations, both cross-culturally and among unique higher risk populations, so military service members and veterans, older adults, so on and so forth. And this culminated in a meta-analysis that we published in 2017 of approximately 125 studies. And together, these studies provided moderate empirical support for the tenets of the interpersonal theory. I want to dive a little bit further into what we're referring to by perceived burdensomeness and thwarted belongingness. So perceived burdensomeness is really characterized by this belief that one's a burden or liability on others, kind of effectively laden with self-hatred. Individuals who are experiencing perceived burdensomeness might describe some of those thoughts or beliefs that are on the slide. And what we found is that perceived burdensomeness tends to be really consistently, pretty strongly related to thoughts of suicide kind of at that moment. Thwarted belongingness, on the other hand, again, that kind of disconnection, loneliness, lack of reciprocal care. Some of the statements that you might hear from patients kind of experiencing thwarted belongingness are, again, kind of listed on the slide here. We typically find that thwarted belongingness is more weakly, though also still significantly related to suicidal ideation by itself. But it's really the combination of perceived burdensomeness and thwarted belongingness that's particularly pernicious. So both perceived burdensomeness and thwarted belongingness are thought to be proximal risk factors, so kind of near-term risk factors for suicidal ideation and desire. So it can also be important to consider which distal risk factors each of these might explain, recognizing that suicidality results from a wide variety of factors. So for perceived burdensomeness, things that might contribute to perceived burdensomeness might be things like psychiatric disorders, physical or chronic illness, unemployment, financial difficulties, older age, homelessness, incarceration. For thwarted belongingness, on the other hand, this might be things like social isolation, interpersonal conflicts, again, psychiatric disorders, older age, as well as shame, among other factors. I'll also discuss for each of these very briefly how you might actually assess for these. I'm going to go through this pretty quickly just for the sake of time, but I do believe these slides are going to be shared after the presentation for further reference. I'm also happy to share any of the measures that I'm talking about today as well. So there's several interview measures or interview questions that might be helpful to ask if doing kind of a clinician-based risk assessment, assessing burdensomeness and belongingness. They can also be assessed through a self-report measure. So the 15-item interpersonal needs questionnaire is the most widely used and validated measure. 6 of the items here are going to be measuring perceived burdensomeness. The last 9 are going to be assessing thwarted belongingness. So next I want to talk about capability for suicide. This concept has been kind of relatively newer to the field, though it's become pretty central at this point, and is thought to be a key factor that's really distinguishing individuals who go on to make a suicide attempt from those who have ideations alone. So when we're thinking about capability for suicide, it's typically this ability to overcome one's evolutionary programming, that instinct for self-preservation. So it's typically comprising fearlessness about death, pain, and suicide, as well as heightened physical pain tolerance. Capability is not inherently harmful by itself. Many people are high in sensation seeking and low in fear and can tolerate a lot of fear or can tolerate a lot of pain. But if you combine this with like suicidal desire, it can be potentially dangerous. In addition to these internal factors, this capability construct is also including this familiarity with and access to lethal means for suicide. So individuals who are knowledgeable about potential suicide methods, so hunters, military, veterans, physicians, so on and so forth, those individuals might be at heightened risk if they experience suicidal ideation. Additionally, the physical proximity as well as the cognitive accessibility or like psychological attachment or closeness has also been found to play a role in overall risk. So kind of the closer or the more accessible, the higher the risk. So again, it can be helpful to think about what distal risk factors might contribute. So this might include things like perceived previous suicide attempts, family history, combat exposure, childhood abuse, chronic pain, even just kind of one's occupation, anything that's going to increase one's dispositional tendencies with regard to fear or pain or death or suicide methods. When assessing for capability for suicide, again, I'm going to go very quickly through this, but there are some interview measures that can be used, as well as some self-report measures. There's honestly very few great ones out there. The acquired capability for suicide scale has been the one that's most frequently been used. I'm currently collaborating with Dr. Thomas Joyner and some of his colleagues, and we have a new measure under review, so I'm hoping that'll be out there soon. So next I want to turn to another predominant theory of suicide. So this is going to be the three-step theory of suicide, which is highlighting the role of some other cognitive affective factors in conferring risk for suicidal desire, as well as the combination between this desire and this capability to determine who might go on to engage in suicidal behavior. So specifically, step one here of the three-step theory is saying that suicidal ideation is going to result from the combination of psychological pain as well as hopelessness. Step two is hypothesizing that among those individuals who are experiencing both pain and hopelessness, connectedness is a key protective factor against escalating ideation. And then finally, step three is highlighting that that progression from ideation to attempts is going to be facilitated by capability for suicide. So I've already talked about capability for suicide as well as connectedness to some extent. So here I'm going to predominantly focus on psychological pain and hopelessness. Psychological or emotional pain is relatively self-explanatory, but just feeling considerable emotional distress. Individuals might say things akin to what's presented on the slide. And then kind of pairing that with hopelessness. Hopelessness is this belief that things are never going to improve, alongside just those strong negative emotions. And it's really the combination of psychological pain and hopelessness that is thought to increase risk for suicidal ideation and desire, according to this three-step theory. So again, there's going to be some self-report measures as well as some interview measures for both psychological pain and hopelessness. Again, just going to zip through these, but I'm happy to talk about this a little bit more later on, as well as just share all of this as a resource later on. I would say it's definitely particularly relevant to assess hopelessness, since hopelessness kind of across the board seems to be a pretty potent risk factor for suicidal ideation. There's also self-report measures that can be used for psychological pain. So one would be the psychic scale. There's also some measures of hopelessness out there. One of the best known, I would say, is kind of this 20-item Beck hopelessness scale. So another relevant indirect risk factor kind of in this cognitive affective domain is going to be rumination, which is really this tendency to respond to distress by passively focusing on the causes and the consequences of one's problems, or just focusing on distress without any form of like active problem solving. So it can also be understood as just like difficulties disengaging from negative cognitive and emotional content. Folks might get stuck on their thoughts and their problems. Rumination has been pretty robustly associated with suicidal ideation and attempts, especially when these thoughts and ruminations have been perceived as difficult to control. There's also some evidence that rumination might actually serve as this catalyst to exacerbate some negative emotions, as well as strengthen those links with suicidal ideation and attempts over very short periods of time. I'll also note that there's some accumulating evidence about kind of specific forms of rumination. So some of my recent work has really focused on rumination and fixations on one's suicidal thoughts or images specifically, otherwise termed as suicide-specific rumination. And there's accumulating evidence that this form of rumination might be particularly dangerous. So here again, I'm going to include some examples of questions that could be integrated into some standard risk assessment interviews to assess rumination. So kind of asking about trait tendencies, about how often you're tending to get stuck on your mind, how you typically cope, could also be a helpful kind of open-ended question to ask. And then there's also, again, some self-report measures that can be used to assess rumination. One of them here is the ruminative responses scale, or the perseverative thinking questionnaire is another one. Again, happy to share copies of any of these measures. And then it's also worthwhile to assess whether participants or patients have experienced any recent stressors. Stressful life events have been tied to suicidality, especially suicide attempts and death by suicide. The research literature also tends to highlight the importance of temporality here. We found that associations with suicide-related outcomes tend to be stronger the more recently that stressful event occurred. And then we've also found that stressors that are interpersonal or financial in nature tend to also be particularly relevant. So again, I'm going to put some potential open-ended questions on the slide here, just kind of to probe into whether anything especially stressful has happened recently, how stressful they actually perceive that experience to be, what impact it had on them. There's also a number of checklists out there for stressful life events. I'm not going to recommend any particular one, since I tend to prefer asking about stressors in a more free-form manner, just to see what kinds of things are going to be relevant to the patient themselves. And then finally, it's worth discussing acute states of hyperarousal as well as severe affective states. Each of these has been pretty strongly linked to suicidal thoughts and behaviors. So things like agitation, which is characterized by kind of feeling like crawling out of one's skin, restlessness, mental anguish, feeling on edge, marked irritability, so acute irritability and frustration, again, kind of being on edge and volatile and reactive. Sleep disturbances, so insomnia, as well as nightmares or disturbing dreams that are waking somebody from sleep. And then finally, there's quite a bit of evidence for severe affective states that are rapid onset and intense emotional states that are kind of resulting in this high anguish and energy. I want to talk a little bit about why hyperarousal is thought to be particularly pernicious towards engaging in suicidal behavior. And that's because it can provide the high levels of energy that might be needed to overcome those survival instincts that I mentioned earlier. So each of these particular factors has been supported through meta-analyses, as well as numerous studies highlighting their role. However, in addition to kind of assessing their presence, it might also be worth kind of looking at changes over time. So if somebody's just started having sleep problems, they might be at higher risk than somebody who has always had chronic insomnia. Again, there's some ways that you can assess for these factors through either self-report or interview questions. So here are some examples for agitation, irritability, sleep disturbances. In addition to assessing and asking about these directly, behavioral observations to see if patients are having these difficulties sitting still, their reactivity, so on and so forth. Those behavioral observations are also going to be especially informative. But there are some brief self-report measures as well. So the brief agitation measure, the insomnia severity index, so on and so forth. So I'm going to go ahead and just put all of this together. This is just one example of a sample suicide risk assessment. I know I've kind of thrown a lot of risk factors at you all at once, so I'm happy to talk about these a little bit more when we get to the discussion phase of today's session. But here's one kind of example form that one might administer. This particular one is called the Decision Tree Framework. It was developed by Dr. Thomas Joyner and colleagues quite a while back, but they've had pretty regular adaptations over the years just based on the most recent literature. So the top half of this interview does focus on current suicidal ideation, intent, plans, preparations, access to lethal means, as well as gathering information on previous suicide attempts and non-suicidal self-injury. Whereas the bottom half of this is going to assess most of the factors that I've described here today. So perceived burdensomeness, thought of belongingness, capability for suicide, hopelessness, stressful life events, coping strategies, as well as over-arousal. So again, I hope the balance here is demonstrating it's not that suicidal thoughts and intentions and past behaviors are not clinically informative. They absolutely are. It's just also worthwhile to consider these indirect indicators, especially if patients or whoever you're assessing might deny or choose not to disclose suicidality when it's there. Kind of as one kind of more potent example, there is some research evidence that military service members and veterans are going to be more likely to disclose things like sleep disturbances or things that they're perceiving as less stigmatizing versus depression and suicidality kind of more directly. And importantly, within this type of framework, even if those direct thoughts of suicide are denied, you still complete the entire interview so that you can get a holistic view of patients' potential suicide risk. So finally, just to summarize and kind of wrap things up kind of with this formal portion of the presentation, especially since we've covered a lot of ground in the last couple minutes, I'd like to kind of return to just a brief summary of what we've talked about. Essentially, my take-home messages here are that assessment of suicidal ideation alone isn't enough. We really need to start integrating some more of these empirically supported and theoretically driven indirect indicators to augment this information, especially when we're working in either higher risk or lower disclosure populations. So before I turn things over to Dr. O'Connor, just want to go ahead and give this frankly shameless plug. So I want to alert, if you're not aware of it, the Suicide Research Symposium is a symposium that my colleagues and I have put on, and for the past, this will be the 4th year of it. It's going to be occurring in April this year. This is a free and virtual conference that has over 300 presentations kind of the latest suicide research. So it's a great place to network and just kind of learn more about kind of what is cutting edge in this field. I also do provide workshops and trainings on suicide risk assessment and management. So probably like 4 times longer than what we're doing here. So if that's something that you have any interest in, feel free to contact me as well. But for now, I will go ahead and put my contact information up here briefly. I'm sure they will share that. Shelby and Lauren will share that, but going to go ahead and turn that over to Dr. O'Connor now.
Thank you so much for sharing your knowledge with us, Dr. Rogers. And just as a quick reminder for everyone, feel free to jot down your comments or questions in the chat, and we'll be getting to those just in a moment in the meeting. Now we'll hear from Dr. Stephen O'Connor, who is the Chief Suicide Prevention Research, the Chief, of the Suicide Prevention Research Program in the National Institute of Mental Health Division of Services and Intervention Research. Dr. O'Connor.
Yeah, thanks. That's a mouthful. Dr. Rogers, that was just a fantastic presentation. Thank you so much. And it was really great to see how much it resonated with everybody who's attending today. So I work at the National Institute of Mental Health. I chief our suicide prevention research program, and that essentially means that I'm a program officer and oversee that portfolio. So we have about 60 suicide prevention grants that are awarded that sit in my portfolio, and I'm in the Division of Services and Intervention Research. So the studies that we're funding are really happening out there in real world clinical and community health settings in healthcare systems, in trying to have near-term impacts on reducing suicide risk in people that receive services. So this is very appropriate. I put together a few remarks, and I can share one case example from time before I came to NIMH, some work that I had done with someone. That'd be helpful, kind of just highlight some of the points that Dr. Rogers was making. So, I really appreciate Texas State University for organizing the event, and suicide prevention is a major priority for NIH and NIMH specifically. Those interested can visit our NIMH website and familiarize themselves with our featured publications of interest, funding announcements, workshops, webinars, and much more. Suicide prevention helps improve quality of life for those experiencing suicide intensity, as well as family, friends, coworkers, and the communities where they reside. And suicide is preventable, and we have evidence-based strategies that work. So I appreciate the opportunity to comment on, the content that was described by Dr. Rogers. Many of you all are probably aware the U.S. Department of Health and Human Services published a new national strategy of suicide prevention. The previous version came out 10 years ago. So there's been a lot of updates that have been made. And we work together across federal government and also with private partners to lay out 4 different strategic directions that will help address the suicide issues within the United States. One of the specific areas, the strategic directions, is focused on treatment and crisis services. So I think that that's really where a lot of the content that Dr. Rogers discussed, where we think about that residing with our national strategy. Essentially, we know we have evidence-based approaches, and one of the major things that we have to do is figure out how do we get these out into healthcare systems and deliver high-quality care to people. And one of the really important components of that is helping to identify those in need, and then determining the level of services that they require. So that's like maybe kind of a nuanced way of thinking about assessment. I think people are acknowledging some of the limitations of using assessments to determining who might be at elevated risk to make a suicide attempt at some specific point in time, and thinking a little bit more about, given sort of the characteristics and the intensity of your suicide experiences, what's the appropriate level of services that you require right now? And there's been kind of a paradigm shift away from thinking about what would I as an individual do to help reduce your suicide risk, and think a little bit more about what would I as part of a health system do to address your suicide risk. So there's systems level approaches that incorporate screening and assessment, but they really work when you combine them with evidence-based intervention, right? Alone, the screening and the assessment probably isn't going to do a whole lot to address someone's suicide risk. And there are some pretty brief things that you can do that I bet a lot of people here are trained to do, things like safety planning interventions and some follow-up contacts, not necessarily non-demand follow-up contact where you send people carrying contacts and things like that, but more of contacting them a couple times after you've provided a safety plan with them, and just sort of checking in with them to see, did you use it? Is it working? What worked and what didn't work? And then are you having any issues with connecting, with kind of a longer term care provider? There's an important distinction to make, I think, between screening and assessment. Okay. So screeners really are intended to take from a larger population a smaller group of people that are identified as potentially being at higher risk. It's really not intended to be predictive as much as it's to shrink the pool so you know where to focus your resources. If you're working in large healthcare systems or within counseling centers, things like that, it's really helpful if you can identify, of all the people that we're serving, which of those do you think that we kind of need to focus on and offer a stepped up level of assessment or care. These aren't perfect, and there are always going to be people that don't come to your attention. There are other strategies that we're funding and systems are trying to develop to identify groups that or people that might not come to your attention. So Dr. Rogers mentioned machine learning approaches, right? It's essentially taking data that's available through, say, electronic health records or claims data, social media data sometimes, and then kind of putting those into risk algorithms or calculators, and then creating dashboards that pop up for clinicians and administrators so that they know who they can proactively reach out to. 50% of people who die by suicide each year do so on their first attempt. So it's really important that we proactively identify people as much as possible. So that's kind of the function of a screener. The assessment, like I was saying, in a lot of ways, it's intended to sort of get a better sense of who's in front of you. And going back to more of my kind of clinical days before I came to NIMH, really kind of using the assessment process in a really collaborative way to think together about why someone's experience makes sense, and what are the preferred and also probably the most effective ways that the treatment plan can start to reflect, what would directly address what is making that person have these suicidal experiences or have increased suicide intensity. So doing that in an overtly collaborative way. And when I've worked with people in the past, was very clear about the ways that I thought about risk management and about our work together. And there were times where people were hospitalized, but whenever that was done, I tried to make that as collaborative a process as possible. But the vast majority of people I worked with who had suicide intensity, we were able to work together on an outpatient basis and had a lot of success helping people with different evidence-based approaches like collaborative assessment and management of suicidality or dialectical behavior therapy. Another one that is really helpful is cognitive behavior therapy for suicide prevention. So there are approaches that we can use, but when we're in this role of we want to be helping, but we also have the expectation to manage risk, through the assessment process, it's really helpful, I think, to be transparent and to communicate as much as you can with the person in front of you so they understand your thinking too. Because you don't want to be making fear-based decisions, and you don't want them to be making fear-based decisions either. They're making fear-based decisions a lot of times. Maybe that's an opportunity where you're not getting all of the information you need to also inform what you're going to do, right? So it's very much reciprocal how that's all playing out. Dr. Rogers made some important points about assessing these indirect factors that may affect suicide risk. I really like the assessment that you presented there at the end. I think within the assessment framework, I think we also want to make sure that we're looking at protective factors. That data that you presented from the National Survey for Drug Use and Mental Health Issues from CDC that's published each year, points out that the vast majority of people who have suicidal thoughts and even those who make plans never go on to make an attempt. So we want to understand why that is, right? And some of it might be related to some of the capacity for making an attempt that was described. A lot of it also might come down to what are your reasons for living? And why is it that people choose to live with a lot of pain and suffering in their life, but they choose to go on living because they have such important things that are part of their lives. And that's part of someone's story as well. So we want to be able to get to kind of understand that experience for someone. So yeah, I think, just to kind of close here, I did some research back, before I came on board at NIMH that was focused on helping people who had recently survived a very serious suicide attempt and they received care on medical surgical floors. So I did that research for about a decade. And first place where I did that was at University of Washington at Harborview Medical Center. It's a trauma center for Washington, Wyoming, Alaska, Montana, and Idaho. People were coming in from all over the place. And, when you are working on a psychiatry consult liaison service, you are walking into a room with someone that's just survived an attempt, and a lot of times they didn't expect to live. And it's a teachable moment, essentially, where you can kind of say, okay, this happened. Now, how do we make sense of this? And how do we prepare you to kind of move forward with your recovery after the suicide attempt? And some of the things that Dr. Rogers was describing about kind of cognitive capacity and with perceived burdensomeness and hopelessness and ruminative thought patterns and things like that. It kind of reminded me of one person that I met on an ICU who had survived. This had been the 5th attempt in 6 months. A very serious attempt that landed this person in the ICU. And they described this very thoughtful journey of doing a lot of hiking in the Cascade Mountains and a lot of ruminating, essentially, and kind of reaching a conclusion that suicide makes sense for them. And we kind of broke that down to help understand how, therapists need therapists. Like, you can't be your own therapist. Otherwise, everybody kind of has their own confirmation biases. And we always tend back to kind of what we believe. We find evidence to support what we believe. So kind of like talked about the importance of not making such a big decision all by yourself, but it potentially is the most important decision you'll ever make in your life. So it's really important to make sure you have all the facts on the table. You're not missing anything. So that was kind of the way to help communicate, how do you identify kind of, when your own thought process might be kind of limited. And if you're depressed and maybe you have trauma experiences, I think a lot of that's potentially going to add to, kind of the constriction towards the hopeless idealization of like, where your life is going in the future. This person also was HIV positive. And so we kind of talked a little bit about maybe how his very appropriate process of having to habituate with a kind of, a shorter lifespan, a more, like his mortality. He had to wrestle with that and then make ongoing decisions about the treatment that he's taking to prevent the HIV proceeding into, more severe form of AIDS. How that process kind of gave him less fear about death and dying. And that kind of fits a little bit with what Dr. Rogers, with that conceptualization about acquired capability too. So there's ways that you can, as you become more facile at kind of understanding the literature, but also just understanding like the phenomenological experience of like how people, why it makes sense that people have these experiences, it allows you, I think, to like weave in your understanding of these theories into some of the assessment process so that it becomes therapeutic. An assessment is an intervention, essentially. Everything we do with people is intended to be therapeutic. So it's not like you just do an assessment and now you're going to do something that's going to be therapeutic. That's not the way that someone who's receiving care experiences it. So there's ways that you can think about the collaborative therapeutic process with people. Okay, so I'll stop there. I too could talk longer about this. Really passionate about this topic, but want to open it up to others to share their thoughts. Okay, thank you.